So, uh, first of all, I would like to thank our speakers in preparing their presentations today. So I'll just run through our three speakers and their respective topics. So Dr. Layan Allawi is a hematologist at London Northwest University Healthcare Trust and is also a Darzi Fellow there. And she has given an introduction to sickle cell disease. Elizabeth Olukoga, who is the specialist pediatric sickle cell community nurse for Harrow and Brent, is presenting on how to manage sickle cell in an educational setting. And then Dr. Rebekah Easton, who is the pediatric psychologist at St. George's Hospital, who works with children with sickle cell, is discussing the psychological impact of sickle cell and how this can be helped in a school setting as well. So, Layan, if you're ready to present, I'll be quiet at this juncture.
Thank you, Ralph. Thank you all for coming. So I'm going to squeeze in all I know about sickle cell in 10 minutes. I know that some people on the call might have not come across this condition before, and maybe not met someone with it before either, and that's understandable because sickle cell disease is relatively uncommon. About 15 to 17,000 people in the UK have sickle cell disease, and that classifies it actually as a rare condition. But the prevalence is rising. So we have it now affecting 1 in every 2,000 births, but previous years it was 2,500, 2,000, nearly 3,000. So the prevalence is rising. And the most common places you would find sickle cell is in cities like London, Birmingham and Manchester, quite diverse areas. And it's making it one of the most common genetic conditions in the UK. So much so that it's part of the newborn screening program. All mothers who are pregnant tend to get screened for sickle cell or the carrier status, and all children born in the UK have the heel prick test, which assesses for sickle cell. So the way that sickle cell is inherited is called an autosomal recessive inheritance, and that means that for someone to be affected with sickle cell, both parents must have the gene to be passed on through to them. And so either you have both parents who are carriers, or one parent who has the condition and the second being a carrier. You get one from each parent. Really interestingly, the reason that sickle cell, there is a benefit to being a sickle cell carrier, and this will explain the demographic distribution of it. So those who have a carrier status, i.e. they have the gene but not both, generally are asymptomatic. But in terms of prevention, in terms of its benefit, it offers a better it offers more immunity against a specific type of malaria. And so over the years, you'll find that where there is malaria, there is sickle cell, because of the protection that the sickle cell trait offers. Now, you can see here on the graph that highest places of sickle cell, highest incidence of sickle cell is in sub-Saharan Africa, but you can see it across Middle East, Asia, and South America. But now, as people migrate and move along, this demographic is likely to change due to our habits of moving across. And so we have a higher prevalence in the UK year on year. So much so that we're expecting sickle cell anemia to rise by 1/3 in 2050. And this was a paper published in 2013. So the condition itself affects the red blood cells. I'm just going to talk to you a little bit about red blood cells because it is a hematology condition. So red blood cells are packed in the bloodstream. There's about, in one drop of your blood, there'll be about 5 million red blood cells. And these red blood cells are perfectly designed to travel through tight capillaries by their shape, these donut shapes that can fit together and squeeze into small capillaries to get to the organs of your body. And the main function of these is to deliver oxygen. And each red blood cell, there is hundreds of millions of these proteins called hemoglobin, and they carry the oxygen through to the organ it's supplying. Now, the problem with sickle cell disease is that it affects the the coding in the DNA that codes for hemoglobin. And so in sickle cell, instead of having these red blood cells that can perfectly fit through small capillaries, if triggered or exposed to any of the triggers of or stresses that they have, these red blood cells change formation and become these sickle-shaped cells that are hard, rigid, and sticky, and they are likely to cause blocking in the capillaries and in the vessels. So I talked about a few triggers. So these can include stress, infection, cold temperatures, dehydration, high altitudes, and so sometimes that can also include pain, and I think in some cases even scuba diving, but hopefully no one with sickle cell disease is scuba diving. Now, the way that sickle cell can manifest is huge, and although it affects just the protein in the red blood cells, the effect of that onto the person is huge. It probably could be covered in a book, but I'm going to cover it in a slide, and mainly the things that need to be kind of drilled home. The first is vaso-occlusive crises. These sickle-shaped red blood cells can block off vessels, and that can cause extreme pain. Now, the pain can be managed with some painkillers at home, but sometimes this crisis needs really strong painkillers, and it's not uncommon to use something like morphine even in children. These crises can affect different organs in the body, and the complications of that can be life-threatening. I put here a picture of it affecting the lungs, and that's a medical emergency. And people who have sickle cell, who describe pain in the lungs or have symptoms, chest symptoms alongside the pain, need to be seen as soon as possible. Secondly, people with sickle cell disease have, over time, there's damage to their spleen, and spleen is an important organ for immunity, and so they have higher risks of infection. And so during the COVID pandemic, they were obviously a high risk category, and they are also on long-term, lifelong antibiotics. Thirdly, another thing that you might notice in people with sickle cell disease is the yellowing of their eyes. This is a sign of red cell breakdown. So the sickled red blood cells are being destroyed by the body, but the factory of the red blood cells, which is the bone marrow, can't keep up with the destruction of red blood cells, which can cause symptoms like fatigue, lethargy, or feeling cold. And so the way that can manifest is in that way, and one of the signs is the yellowing of the sclera, the whites of the eyes, due to the breakdown product of red blood cells, which is yellow. And lastly, it can affect any organ in the body. It can cause strokes, it can cause eye problems, in the long term can cause some level of sight loss, problems with the kidneys, problem with the joints. Really, it's a huge impact on someone who has sickle cell disease. Now, in terms of the treatments available, there are treatments. So sickle cell is a treatable condition. Like I mentioned, those with sickle cell are on lifelong antibiotics to prevent the risk of, or to reduce the risk of infection. They take vitamins such as folic acid to support the red blood cell production. And they're usually on vitamin D sometimes as well. There are certain disease-modifying agents. This is licensed for children at the moment that they might be on. It's a low-grade, probably chemotherapy at the dose that it's given to promote the type of red blood cell that can live longer in people with sickle cell disease. And then there's transfusion. So again, usually probably if older people with sickle cell disease might be having this maybe 20s onwards. And this is massive amount of transfusions. They can either have a top-up transfusion to support the anemia, or they can have exchanges where they have their blood taken out and donors' blood given in to kind of replace the sickled blood. And I think this might be a good time to tell you a little bit about the campaign about Give Blood, Spread Love. So with sickle cell disease, like I said, the demographic affected are usually Black or Asian, and so ethnically Black matched blood is really important to prevent any kind of complications. And so there's a huge campaign talking about give blood, spread love, especially with sickle cell disease. And finally, the only curative treatment at the moment is stem cell transplant. It is risky, and so it's only offered to certain people who have certain manifestations of their condition. And there's a future of gene therapy and more disease-modifying agents coming out. So I think I'm on time. So quick summary. So sickle cell disease is an inherited condition. Its prevalence is rising worldwide. It affects the red blood cells themselves, but actually has multi-system complications, has a huge impact on those affected with life-threatening complications. So it's really important to act on symptoms of pain and the triggers to prevent the sickling of the red blood cells. There are treatments available and new advancements underway. Thank you very much. And I think I'll take the questions at the end as per Ralph.
Thank you, Layan. Elizabeth, are you able to share your screen for your presentation? Thanks. Elizabeth, you're on mute.
Can you hear me now?
Yeah.
Okay, I'm just going to put it on the big screen. Can everyone see my slides?
Yeah, you're good to go.
Okay. Hi, everyone. So my name is Elizabeth. So I'm the community nurse specialist. I'm going to speak really, really fast because I've got a lot to go through, but I'll try and get to the end. The first few slides is a little bit of a repetition. So don't worry. Let's see how we go, but I'm going to try and finish on time. Aim of the session, what is sickle cell? Prevention of sickle cell crisis, managing sickle cell, children with sickle cell disease in school, and practical measures to support the child in school. What is sickle cell disease? So just to simplify it, it's a condition inherited from both parents that affects the blood. So some of the stigmas are that sickle cell is infectious, it's a cancer, or it's a punishment, but it is not. It's inherited by both parents. So you might hear a lot of stigma, a lot of things around sickle cell, but just to remember, it is an inherited disorder, disease, and it is not infectious. Symptoms of sickle cell: anemia, infection, and pain. These are the three main things that we would say is symptoms of sickle cell disease. So especially in our children, dactylitis, so swelling of the fingers and swelling of the toes. You might get delayed growth, leg ulcers, and the #1 killer, chest crisis. So you might ask, what part of the body does sickle cell affect? So it's potentially everywhere where blood supplies to the body. So eyes, teeth, kidneys, lungs, spleen, everywhere that can be affected by sickle cell disease. So that's a key thing to remember, especially when you're caring for children who have sickle cell disease. Infection in sickle cell disease, most common cause of death, like I said, due to splenic dysfunction. So the spleen is responsible for fighting off things like infection. And with our patients who have sickle cell, they actually have, some of them may have dysfunction in the spleen. So therefore, they're more susceptible, to developing things like sepsis and diseases and bacterias due to the fact that the spleen isn't working as an average child's spleen would be working. So how can we prevent sickle cell crisis? That's through education, having penicillin. So penicillin is the antibiotics that we recommend children from the age of 3 months to take. Having childhood vaccinations, pneumococcal flu vaccines, which I know you give in schools, and obviously having malaria vaccinations when they travel as prophylaxis. Again, sickle cell crisis is concerned with hypoxia, so low oxygen, excess acid, dehydration, infection, temperature changes, and that can actually, sickle cell crisis can be stress induced and also via exercise, doing too much. these things can actually contribute to a sickle cell crisis. So let's focus on hydration. So we advise all of our young people to have adequate water, so to drink 2 to 3 liters of water throughout the day. So we recommend, as good practice, to allow the child to have their water bottle in school at all times. So where you might have, I know in some schools you may not allow the child to have the water bottle on the table. We would actually recommend that you allow the child to have a water bottle on the table so that they're reminded to drink as frequently and as regularly. And again, we know that some schools ask our children to have fill up their water bottles in water fountains. If that's the case, please ensure that the water fountains are kept clean, as we know they are susceptible to having infections. So that's some of the things that we would recommend. Again, with drinking water, it's obvious that they would need to use the toilet a lot more. So again, in our care plans, we recommend every child should have a toilet pass where they can go to the toilet as and when they need. And just to avoid the embarrassment, I know some of our kids complain that, they don't drink enough water in school, and we ask them why. They say because, well, Miss doesn't let me go because she thinks I'm messing around in the toilet or just being disruptive in class. Or actually, if you think about it, if they're drinking a lot of water, that goes without saying that they're going to need to go to the toilet regularly as well. Temperature. So as we know, sickle cell disease is triggered by extremities of weather, so being too hot or too cold. So good practice, we would definitely advise for the child to be, in a well-ventilated room. Avoid being sat next to the door or next to the windows, just because, again, it's triggered by extremities in temperature changes, so too hot, too cold. And in the winter months, we definitely say that the school should be allowing the child to have exceptions in wearing extra layers, so being warmer, hat, gloves, scarves, things like that, or even like extra layers under their uniform if they are wearing uniform, and avoid activities outside if the weather doesn't permit them to do so. And you could think about things like allowing them to remain inside during break times and lunch times, obviously supervised by an adult where possible. Physical exercise. So again, this is another thing that could trigger a sickle cell crisis. So we do encourage all of our children to participate in PE, but good practice would look like this: allowing the child to express, when they're too tired, they should be allowed to sit out and participate in other ways. So let's say, for example, you're playing basketball outside, it's on a cold day. If it's too cold, number one, they shouldn't be outside. If it's moderate enough for them to be outside, allow them to participate, perhaps by point scoring or keeping keeping track of who's winning, things like that, getting them involved in other ways rather than them running up and down the court, running up and down the football pitch, getting them involved in various ways, not making them feel left out. Again, we're trying to protect them and prevent them from having a sickle cell crisis. If you are if you need any extra advice, then you can contact the medical teams. Each child should have a specialist nurse or specialist center where they're treated. So it's important for you to get those numbers and have that on board so that you can discuss how to protect that child in school. Swimming, that's another thing that we would recommend that children should actually participate in. Again, sickle cell children who have sickle cell disease are advised they can go swimming, but make sure that the pool is not too hot, not too cold. I know you sometimes can't control that, but if they are going to swimming, the key thing is once they come out of the pool, making sure that they dry up quickly, change clothes, kept warm, and regulate their temperature again. So we don't want them to feel excluded, but we do want them to be protected and to be to feel that they can actually participate in other sports like the rest of their peers. Right? Physical exercise continues. So again, we're doing exercise in everything that we do. Speaking is an exercise, walking, things like that. So where the children may be in older schools where they're carrying different books for different subjects, we'd advise you to allocate to them a locker so that they can put their books in the lockers. They don't have to carry that around to different classes. Where they're in primary school, they might just have that one class and just might have a book bag. that would be okay. They might not need a locker in primary school, but in secondary school, when they're carrying extra books and things like that, we would ask that you consider probably giving them a locker or giving them a lift pass again, so they can use the lifts to get to their lectures or get to their lessons in a timely manner rather than walking up several flights of stairs. Managing pain. So with our younger children, you may not be able to recognize that they're in pain quite quickly. And what we would recommend is understanding the child who has sickle cell. Are they normally quiet? Are they normally a loud child? The changes in behavior would actually make you think, okay, maybe this child's in pain. Again, check their toes, check their fingers. They might have some swelling in their fingers, in their toes. This would represent them having a crisis, something called dactylitis, which I explained earlier on. Offer them fluids, allow them to have a place for rest so that they can rest if they do feel tired, because as Layan was explaining that, it's an anemia, so they may feel tired more than other children in the classroom. And we do recommend that every single parent should bring their child paracetamol and ibuprofen in school. So this is sort of the first line treatment that we would recommend. So if parents consent to you doing so, giving them the paracetamol and the ibuprofen, contact your parents and seeking medical attention if you are worried or concerned about the child. Urgent medical attention. So these are the situations where you want to be phoning 999. You want to be contacting the parents, and you want to be escalating as soon as possible. So if the child has a temperature of above 38 degrees and it's not coming down by paracetamol and ibuprofen, you want to be phoning the parents. You want to be getting them seen in an hospital so that we can control and manage their temperature. If they're in pain, breathlessness, that comes without saying. If they can't breathe or they just seem completely out of breath and nothing is helping, again, you want to be seeking further medical attention. Complaining of chest pain, severe abdo pain. So I put here parapism. So parapism is a prolonged erection which males can get. And it's really, really important. If the child is complaining of a parapism, prolonged erection of the penis, we want to get that child to hospital as soon as possible, because if that's not corrected, then potentially they may never be able to have an erection again if it's not corrected adequately in a timely manner. I say this trying to really put emphasis on this because we've had a patient who didn't seek medical attention adequately, and obviously there is long-term consequences for that. If they're drowsy or unresponsive, have a severe headache, or if their limbs might look weak, or they can't lift their hands, they can't move their legs, you want to be seeking medical attention. Dial 999 to call the parents, tell the ambulance that this child has sickle cell and they're having a crisis. You think they're having a crisis, and explain the symptoms that they're having. So every child in the UK, London, should have a healthcare plan explaining sickle cell disease, what sickle cell disease is, signs and symptoms, what to look out for in case of an emergency, and key contact details. So I'm not sure who's on the call and what areas you are in, but especially in Brent and Harrow, we have individualized care plans, which every child with sickle cell disease will have in school. We encourage the teachers to be aware of the child, their conditions and their symptoms, because with sickle cell disease, it's not like you've cut your hand. It's not like I don't know, like a cancer. It is individualized. Every single child may have different symptoms. That's the thing with sickle cell. It's very difficult to, it's not a one hat fits all sort of approach. It's individualized, and that's why it's important to have an up-to-date care plan, which will be, updated on a yearly basis or as and when needed. School absences. So as you are aware, these children who have sickle cell disease, they come to hospitals regularly to have clinics. So that unfortunately can't be helped. They're going to be missing school because of that. Sometimes if they are in crisis, they will have to be admitted, and that can come with weeks, sometimes weeks, sometimes even months being admitted to a hospital. So this is really why we try to hone down on understanding that, every child has different symptoms, and we need to protect that child to avoid them being inpatient or to avoid them having admissions for weeks on end. And how can we help these children who are in hospital? We recommend things like having catch-up sessions. I'm not sure, I know in COVID some schools had virtual sessions, so for the purposes of children with sickle cell disease, perhaps that might be something that you might be able to explore, and maybe lunchtime catch-up sessions as well. Those are sort of the things that we would recommend. Some children can experience silent strokes. So a way for you to identify when a child might be having a silent stroke might be things like changing in behavior, changes in concentration, sudden deterioration in quality of schoolwork. 1 in 5 people with sickle cell disease have a small area of their brain damage, which is evident on MRI scanning. So every child who has sickle cell type SS, we regularly do a TCD, transcranial Doppler, which is a scan of their brain on a yearly basis. And sometimes we do see changes in those images. And that could be down to things like having a silent stroke. So it's important for you to understand the sort of the symptoms of silent strokes. These are changes in behavior, changes in concentration, and to escalate that as soon as possible, letting us know, letting the parents know, and where you're concerned or worried, obviously 999. Supporting education and learning. So this aims to ensure that the child reaches their full potential and feel supported. With things like exams, so stress is a factor that can contribute to a sickle cell crisis. So with things like exams, we do find that our young people come to A&E or their sickle cell crisis is induced by exams. So prior to having exams, we would say that you put in things like extra time for them to have rest breaks and for them to have extra support. And that can come in things like an EHCP plan. So where you might get a one-to-one for that patient or that child in school, so that they can have extra support. It's important for them to feel supported to reduce that anxiety and reduce that stresses prior to having an exam. Emotional well-being. So I'll leave this to our psychologist, who you will speak to in the next presentation. But again, good practice in schools, making sure the child has a key person so that they can contact if they are feeling overwhelmed, because you've got to remember that sickle cell disease is a lifelong chronic blood disorder. So they need to have a key person they can contact to so that they can speak to that person if they are feeling low in mood. Encourage the child to tell a few friends about the condition. Some children may not want to tell anybody, and that's fair enough. But where the child does want to share that with some of their friends, do encourage them to tell some of their friends so that their friends are aware and they know what to look out for as well. Consider school counselling. Some schools have counsellors, so tap into those resources in school. And then obviously tap into us as well, tap into our resources. So speaking to the specialist nurses, the psychologist, and on the care plan, all of those numbers will be there and contact details will be there. So it's important to tap into that as and when you need to do so. So these are the useful websites. So this is recorded, so you'll be able to tap into these resources. So it's important to keep up to date with your knowledge. And yeah, I think that's it. Sorry, I spoke really fast, but I hope I covered everything. So thank you so much, and I'll leave the questions to the end.
Thank you, Elizabeth. That was excellent. Rebekah, are you able to share your screen?
Bear with me 2 seconds. Okay. Hopefully you can all see that.
Yeah,
and
I
hear
can
me.
see the slide. Yeah,
Brilliant.
and hear you.
Great. So my name's Bex. I'm a clinical psychologist in the paediatric haematology team at St George's Hospital. So I'm going to talk a little bit about the psychological impacts of sickle cell. Just to explain a little bit about my role. So I am embedded within the paediatric haematology team and work alongside doctors, nurses, pharmacists, dietitians, anyone within the hospital, the school hospital as well. Just to kind of flag, I guess not all hospital teams will have an embedded psychologist. St George's is a tertiary centre and has links with other hospitals. So if you are if your child at school isn't supported with a psychologist in their hospital team, there will often be links to a tertiary centre where someone like myself will be able to provide that family and that young person with some support. The main areas of my role are helping children to understand their health, helping young people to manage their health conditions and things associated with it, thinking about education and learning. My role is a little bit different to Cam's, and children can access support from both teams at the same time. It's not a one each or one or. So please do bear that in mind when you're thinking about who's the best person to support a family. As we've already kind of heard, sickle cell can affect everywhere that blood flows, and I just think this is a really useful visual reminder of all of the complications that a young person can experience in the short term and in the long term. And I'm going to touch on a few of these today, such as neurocognitive dysfunction. We've also heard a little bit about treatments that young people are experiencing, and I guess just to flag that for a young person growing up, school can be a tricky time as it is, without having to juggle and manage a long-term health condition. And actually daily medication or monthly blood transfusions, which lots of our children are on, kind of distract and take time away from the things that young people really want to spend time doing, you know, with friends, family, school. And so it's an extra thing that a young person is managing. How I like to think about it is, imagine that a child's got an invisible rucksack on and they've already got kind of homework in there, managing relationships with friends, and then perhaps family difficulties that are going on. And then if you add in an extra thing in that rucksack of having to take medication or having to come for blood transfusions or experiencing pain, that rucksack is getting heavier and heavier and harder to manage. And so it's more challenging for that young person in their day-to-day life. One of the first things that I always think about is, what does a child or young person understand about their health? As we've already heard, you know, understanding what the blood cells do is really important. And I typically refer to donut blood cells, so those red blood cells that are round. And then we've got the sickle cells, which are more kind of banana shape. That's how I talk to very young children about it. And we really want to encourage young people to understand as much about their health condition from a really young age, because we know that knowledge is power, and we know that knowledge can bring understanding about medications and why medication is important and the role that it does. If you're just being asked to take a medication without really understanding what it does, the chances are you're not going to be very motivated to take it, and it's you're more likely to not take it. So actually supporting a child to really understand their health condition and to ask questions to the doctors and nurses and psychology team is really helpful. And if they're asking questions to yourself and you feel like you don't know the answer, please don't feel like you have to know the answer, but it can be more of a fact-finding mission together where you ask to contact their hospital team or parents and think a bit more about it together. What can be really helpful is children understanding in an age-appropriate way what can happen if perhaps they don't take their medication, so they might be more likely to become unwell. So that can be really helpful. We've already heard about for things that can increase the likelihood of a crisis. And sometimes I hear teachers or parents say to me, oh, it appeared to come on out of the blue. We weren't really sure why they experience pain, or it's been happening a lot recently and we're not really sure what the trigger is. You know, we've kept them warm, they've been really hydrated. And actually in that time, keeping a pain diary is something that is really, really useful and really helpful, because it helps, how I explain it is like becoming a bit of a detective and helping us to think about what actually might be underpinning this pain or the fatigue that a young person is experiencing. So things like where is the pain? What was the young person doing just before they experienced pain or at the time? And then recording some other things as well, like medication that was given, other things that they tried, and if the pain rating comes down. And the reason for keeping this pain diary is because I'm going to talk a little bit about the impact of stress and worry. And actually, sometimes this pain diary can help us to understand perhaps periods in a child's day where they're perhaps feeling more stressed and worried, but they don't feel able to articulate it or share it. And this can help us to see patterns perhaps over the weeks or months, if it's always a Monday morning or it's a particular lesson. So that can help us to really target intervention and support to make it as meaningful and useful as possible. Just a little bit about pain from a psychological perspective. So we know, I describe pain as there's many ingredients. When you're making cake, there's many ingredients that go into it. Pain is really, really similar. So of course, we've got the biological process of pain, which is the change in blood cells from those donut blood cells to those banana-shaped blood cells. But we also know that there's many, many other things that can, how I explain it is turn up the volume or turn up the intensity of the pain. And those are things like sleep, how a child's feeling if they're worried or anxious or low in mood, their past experiences of pain and perhaps memories of past hospital admissions or worries about what might happen in a hospital admission, how people respond to them when they are in pain, and perhaps their own thoughts and beliefs about what that pain might be a sign of, or if they might be worried about it. And how psychologists understand pain is in a biopsychosocial model. So that's thinking, of course, about the biological factors, but also about the psychological factors like attention, worry, our beliefs about pain, how we feel able to cope with it, and the social factors. If our friends know about it, if we feel able to tell people, if we feel like we will be believed, if we feel like people will be able to help us. And actually, there's a lot of research to show that the role of stress influences our nervous system, so the part of the body that controls bodily functions like blood flow. Mental stress can decrease blood flow, and what that does is increase the probability that red blood cells will become stuck and sickle, and then that leads to pain. So it's really, really tricky to separate out the biological from the psychological and the social factors. It's very much interwoven and a kind of web of different things. One of the things that we talk about really regularly with schools and with families is a cycle of worry and pain that young people can be really easily caught in. So for example, I think someone mentioned earlier about exams. Naturally, lots of young people worry about exams. I think that's really typical, or worry about perhaps a certain subject and not doing well in that subject. That worry can lead to feeling kind of stressed and anxious, which is really common. For young people with sickle cell, that can increase the likelihood of them experiencing pain. In some cases, that can mean that young people might need to visit hospital for a possible admission or a review. And as we've heard, sometimes hospital admissions can be a review for a checkup and they can be sent home with some medical management, but other times, more likely, it is that they will be kept in from an admission, and then they will miss schoolwork, and then going back to school creates more worry about classroom learning and what they might have missed, what they will need to catch up on. They feel more stressed, and so this cycle can continue, and it's really, really common for young people to get stuck in this cycle at all ages. Often we think mainly around GCSE and A levels, but actually this is really common for young children as well, perhaps where they don't feel so able to articulate the worry that they're experiencing about classroom learning, or the challenges that they're having in classroom learning as well. And we know that teachers are really busy and perhaps might not always be able to pick up on some of the worries that young people have. Thinking about, again, that invisible rucksack, and juggling health and school, where young people do need time off. It's what some of the things that can be really helpful is schools planning how they can support a young person if they were to miss school, either through a hospital admission or through a planned admission, for example, for a blood transfusion. If they're going for a blood transfusion, typically that is a preventative treatment, preventing kind of experience of pain. And we would always encourage young people who are coming to St George's for blood transfusions to bring some work with them so that the hospital school can support them in completing that work. They're not typically unwell at that stage, so they're able to do work for that day admission. However, for longer admissions, our hospital school will support young people where possible. But actually it's that going back and planning how a child can be supported to catch up on the work that they have missed. Often it's really hard for young people to prioritise work, and it's really hard for parents to know what needs to be prioritised as well. So supporting young people to choose the subjects to prioritise and helping them to go through that work in a one-to-one setting can be really helpful. Speaking to parents is always really supportive and helpful, and help creating a plan together. Some young people will require additional support, and actually one of the things that we recommend is a kind of touch point in the week with a trusted teacher, so that young people can develop a really good close relationship to enable them to share when they are in pain, when they're not feeling well, when they're feeling worried. Because often it's the sharing information, for example, like sharing if a young person is experiencing priapism, which is the key to then enabling medical support and intervention, but also psychological support to be able to put into place. Often schools have ELSA as well, which we would really advocate for young people being tapped into. That can be really helpful. So please don't feel like just because a young person is accessing psychology in the hospital that it precludes them from ELSA support. For some young people, they might benefit from further educational support due to cognitive impairments, and I'm going to talk a little bit about that later on. But one of the things that is included in our individualised healthcare plans, which are sent out to schools, is a pain plan. And this is a really useful tool that schools can complete with the young person in a collaborative way to think ahead of time, what can school do when a young person is in pain? And you can see we've got kind of, different levels of pain. And what can the young person do? So some of the things that we recommend is thinking about where on this pain thermometer or pain scale would it be helpful for schools to call parents to let them know that their child is in pain? Where does the young person feel like they're able to take paracetamol and ibuprofen and stay engaged in a lesson? Or where do they feel like actually they need to go to a rest room and have perhaps 20 minutes rest while that medication kicks in before they are able to reintegrate into the rest of the class? And one of the big things to think about is, how will a child communicate when they are in pain? Who will that communication B2, and then what's the plan that will be in place. So this collaborative document really helps children and young people to feel like there is a plan in place for if they were to experience pain, and for them to feel more confident in letting people know. One of the things that I hear really often is that children feel nervous about telling teachers, and that's not necessarily because of anything that teachers have done. It's more because it can be really hard to put your hand up in front of a whole class and let teachers know. So thinking about non-verbal communication methods, like can young people put a pain card on their desk or a card with a symbol on to symbolize to teachers that they are in pain, and then a teacher come over and talk to them and check in with them. Again, this is really different for different age groups, so that's why it's really important that it's a collaborative kind of document. I'm really conscious of time, so I'm going to rush through. But attainment difficulties, the research tells us that cognitive difficulties are really common for children with sickle cell, and that is because where blood flows throughout the body, there can be damage. We know that blood flows through the brain. Stroke is sickle cell is the leading cause of stroke in children, and we know that cognitive difficulties, especially surrounding attention and concentration, are really common, and that is because of how the brain works and the network within the brain. It's a really vulnerable area for children with sickle cell. At the hospital, part of my role is to carry out something called a cognitive assessment that looks at a child's overall level of functioning, thinking about things like their processing speed, their working memory, their verbal comprehension, their visual spatial skills, and then their overall IQ, or their cognitive ability. This does not replace an educational psychology assessment. It is not generally a diagnostic assessment. It looks to see how the blood flow in the brain and how a child's health has affected their cognitive ability. And then I generally make recommendations to schools and families about how a young person might be supported, which are very individualised. If you have concerns about a child's academic attainment, we would really urge you to share these with families and contact their local hospital team to share those concerns as well, because it might be that a cognitive assessment is indicated. You can also tap into your local educational psychology resource as well. They are also able to do these types of assessments. However, they might not have, educational psychologists might not have as much understanding about the impacts of sickle cell, and we can't always expect them to. PICA is something that I'm just going to finish on. It's often something which is not very well thought of with sickle cell. When we hear about PICA, we generally associate it with autism or perhaps learning disabilities, and that can be more of a sensory feedback that a young person is seeking. What we know is that young people with sickle cell, about a third of young people will go on to develop PICA behaviours at some point. And that there's some tentative research which has linked it to a change in haemoglobin, and we know that sickle cell affects haemoglobin levels. PICA is a craving or an eating of non-nutritional substances. Often these can be things like toilet roll, tissue paper, cotton buds, baby wipes, kitchen paper, pieces of paper, and it is very, very common. It can cause abdominal pain. Because if you're eating something which your body can't digest, that's understandably very painful. Depending on what a young person has eaten, it can be very dangerous as well. Things to look out for at schools are chewing of sleeves on cardigans, jumpers, blazers. If a young person wears a hoodie, those drawstrings, very common as well. We often think biting at the end of pencils is very normal, and of course it is, but that's just something to be mindful, especially if a young person has sickle cell. Spending longer in the toilet just because of toilet paper, paper towels that young people dry their hands on, or if you notice that a child is handing in work with perhaps corners of the page ripped off, that is also a telltale sign. If you are concerned about a young person having PICA, please do monitor what items you think a child may be eating, and let the parents know, or the medical team. Please do not tell a child off, because often PICA comes with a lot of shame. Young people often know that they shouldn't be eating paper or these items. And if you've got a secret that you're trying to keep and then someone outs you on it and tells you off, it can be really shame-inducing. And what it can do is encourage young people to hide it more. So actually, we want to try and come alongside a child and supporting them in refraining from eating these types of substances. And that's where psychological support is really important. And if you are working with a young person who has pica, schools are often invited to attend part of that psychology session just to understand more about it. This is a very whistle-stop tour, and also understand more about how they can support young people, because it is a real systems approach to supporting that child with a very innate craving, which they don't often have control over. That is the end. So I think we've got a bit of time for questions from everyone.
Thank you so much, Bex. That was a fantastic presentation. And thank you to Layan and Elizabeth. Yeah, so on to questions. If people would like to either put them in the chat, or there's a raise your hand function on Teams, which you can click on to ask a question in person. So the first question comes from Michael. A quick question. We have a child in year 6 who joined us a couple of weeks ago who has sickle cell. He is only with us until next week. Each day after eating his lunch, he says he is still hungry. Is this common? Elizabeth or Layan, is this something you'd recommend?
Layan, did you want to take that?
I don't know. I don't think I know the answer to that. I actually have to say also I work with adults, so I can assume that maybe if they're feeling fatigued, then they might be feeling hungry. Does Elizabeth want to, or even Bex?
Yeah, no. So I wouldn't say there's like a direct cause and effect relationship between the two. Yeah, perhaps they finish their meal and they're still hungry, perhaps offering them extra snacks. The child might be on a medication called hydroxycarbamide, which we know increases their appetite as well. So it could be that. So I would definitely say encourage them to, if they are still hungry, just have maybe like tell parents to bring in some snacks where they can, they can have the snacks when they're feeling more hungry. But it could be medication that they're on.
Thank you, Elizabeth. The next question is from Judith. Can persons with sickle cell trait experience symptoms, or are they purely carriers?
We can take that one. So they're carriers, and they generally don't have any symptoms. But in certain extremes, whether it's high altitude or apparently even like really deep diving, they can experience crises. But generally, they can kind of cruise by life and not know they were carriers of sickle cell at all, unless they got their bloods checked.
Thank you, Layan. Next question is from Polly. I didn't realize pica was a symptom of sickle cell. Is it known why this is?
Polly, you're not alone. It's not very well. The link between it isn't very well researched, and unfortunately, because of that, and lots of other systemic reasons as well, there isn't a known cause of what actually contributes towards a young person with sickle cell experiencing pica. There's some research which suggests it could be kind of zinc and iron levels, and that it's to do with the child's hemoglobin, but we don't have, we can't answer that question confidently. We just know that there is a much higher prevalence of young people who experience pica who have sickle cell.
Thank you, Rebekah. The next question is regarding swimming. What is the ideal temperature of the pool? Are there specific temperatures that are dangerous?
So there's not a specific temperature. I would just say a warm pool is probably the best. Just the reason why we mentioned about the swimming pool temperatures is just because sickle cell crisis is induced by too hot and too cold temperatures. So if the pool is really, really cold, I would, avoid the child going into the swimming pool. But yeah, there's not an ideal temperature. I would just say a warm room temperature is fine. And as long as they're coming out of the pool, drying up, changing clothes as soon as possible, that's the key thing as well.
Thank you, Elizabeth. One next questions is, can you briefly talk about psychological support offered to the parents? But basically, is there any attached to either the paediatric teams or associated adult service?
Yeah, so I think every hospital might do this slightly differently. I can only speak to what St George's does, I'm afraid. In St George's, myself and our clinical nurse specialist run a nurse psychology clinic. That is first and foremost when parents of babies when the babies are diagnosed, we offer a kind of nurse psychology space to help parents understand the diagnosis, and if there's any shock or if that's perhaps new news to parents, help them process it. From that nurse psychology clinic, then I offer parents psychological support to help them manage what it might be like parenting a child who has a long-term health condition, and to help them adjust to that diagnosis. I offer support up until the age 0 to 18, so parents can tap into support and then leave at any time knowing that they can come back. So parents are supported. I think there's some other questions about other psychological support as well. So generally, some of the things that we psychologists support young people with is pain management, how to look after themselves and how to tell their friends can often be a big one, which I think Elizabeth alluded to. And sometimes that can be having conversations with parents as well about how do they tell extended family, where perhaps extended family aren't always aware of a child's condition.
Thank you, Bex. The next question is, what is the timescale of a sickle cell crisis?
I think we're talking about onset. Is that what we're? So it can take. I think a lot of patients who I've spoken to say that they can feel it coming on, and so it starts in one place and then can manifest over hours. But generally, people who have regular crises can actually tell when the crisis is developing and how long it will take before they need to be in hospital. So a few hours if they don't get the medication, their pain relief in time. So I would say it can take a few hours to kind of get to its peak, but if someone's experienced a trigger that they know that will trigger a pain crisis as well, they're anticipating something. Elizabeth, did you want to add anything to that?
No, I think you said it all really. Yes, you're right. They normally know, sometimes they complain of back pain or arm pain or something, because they already know, where they tend to sickle first. And it's that at that point when they're complaining of that pain, that's when the crisis is starting. So it could be, it could be quite soon or it could be hours. It just depends. With sickle cell, it's like I said, it's very individualistic. Each individual is different.
Okay, I'm going to pick out Tanya's question. Karina and Reja, what I'll try and do is pick up your questions with the team later on. So if I try to scroll back up. So Tanya's question was, would a school need a healthcare plan for a child who's been identified as a carrier at all?
So where I was working before, in my previous borough, yes, some children who were traits had a care plan, and that's only because they had symptoms. It's very rare for people who have traits to have symptoms. Mostly, no, I would say no. In the borough I'm working in now, Brent and Harrow, we don't do care plans for children who have traits because they don't experience any of these symptoms and it's never come up. It's usually for children who have the full-blown sickle cell and not traits.
Thank you, Elizabeth. Thank you to everyone who's submitted questions. And again, thank you to our excellent speakers, Rebekah, Layan, and Elizabeth.